So I'm eagerly awaiting the next presentation from Dr. Mark Hyman, who will be presenting a talk on a COVID-19 primer. And then after a short break, we'll present a second talk on COVID-19 vaccine and variants. For all you that don't know, Dr. Hyman is an internist and is a nationally recognized disability expert. He practices in California. His internal medicine research and interest have expanded to include headaches, smoking cessation, spinal disorders, police arrest techniques, tuberous sclerosis complex, impairment, and workers' compensation issue. He is co-author of several books we, as medical legal evaluators, reference daily. He's co-authored the AMA Guides to the Evaluation of Disease and Injury Causation, second edition, AMA Guides to the Evaluation of Workability and Return to Work, second edition, and AMA Guides to Navigating Disability System. He is also contributing editor to the AMA Guides to Evaluation of Permanent Impairment, sixth edition, 2008. Dr. Hyman provides medical legal evaluations for a wide variety of legal and insurance organizations. Dr. Hyman is a past president of IAM and a huge supporter of IAM's CME mission and the Society for Disability Prevention and Management, SDPM Foundation. Please give a warm welcoming applause to Dr. Hyman. The mic is yours, Dr. Hyman.
So I don't know if you know this, there's been a pandemic. So we're going to try to go through this. I can guarantee you that none of you have the most recent version of my slides. That's because this information comes in big waves, and so I am on my slide set almost every day, usually 6 days a week, tweaking. So there will be the most recent version today, which will be different from yesterday and probably be different tomorrow. And what you can do is know that the majority of the information is in the information that was given to IAM. So that is available to you, and if you want any updated references, it's certainly available. Also, to try to keep the slides somewhat coherent, I decided to move most of the references into the notes section of the slides as opposed to on the slide themselves, because there's so much information that I'm going to have to go through to try to get us all near a same page. So I apologize for that, but the purpose is to try to communicate to be as helpful to you as possible, because certainly I am, and I'm sure some of you are either professionally or personally dealing with a lot of issues here. And the information that I'm going to give you is geared towards being able to analyze people if you get a claim in front of you of somebody claiming coronavirus on a work-related basis that could help you in analyzing what to do. Because there's so much information in my ongoing discussions with your leadership under Fabrice and everybody, which thank you very much for asking me to come, it just turned out that I just kept having to do more. And so that's why we're going to be together for a little while here. And hopefully you'll find it quite helpful for yourselves. Okay, here we go. Let me see, this should do it, and it does do it. So here we go. These are people I have to give thanks to. Always like to give thanks. These are three of my boys that I always give thanks to. And also the boss is here, the wife is here, so be on good behavior, everybody. The books. Whenever I speak to medical organizations, I do have to disclose all the conflicts of interest, which are the books, which have royalties associated with them. Most of you have heard these. Bob was just talking about the causation book. This is the Return to Work book, the Guide 6th edition that I worked on. This is Disability Benefit Systems, which was led by Les Curte, who I think is also here. And this is very helpful, especially if you're new to the field of wanting to know how to do evaluations. This short reference can be very helpful for people to know the basic concepts. With respect to corona, we have this most recent version. We are now working on an updated version of the ACOM guidelines for coronavirus, and we hope to have that out within about a month or so. The document is quite long, currently about 150 pages, but don't get blown away by that. The vast majority of the recommendations and statements are occurring within the first quarter of the document. The rest is scientific justification for the opinions. Some of the other things that we've written that have been published in the AMA Guides, the AMA Guides newsletter, State of Tennessee, are all there for you, and those are also available for a review. There was an article that we put in to JOEM that also has some of the comments that I'm going to be using today in this presentation. Okay, what I will not be covering. I will not be covering masks, schools, air travel, and the vaccines. I decided to cover it. And what I say right now, it could be changed by the end of today because of the way the information is coming at us so much and so fast. Okay, the virology. So this is the first section I want to talk to you about. Just a reminder that SARS-CoV-2 is a beta coronavirus, is an RNA virus. And remember that 10 to 30% of the common colds are due to the other coronavirus. We have all had coronavirus. We may not have had SARS-CoV-2. We may not have had one of the variants yet. That's possible, although data I'll show you later says it's almost probable you've had at least one of them. But you've definitely had, throughout the course of your life, at least one of the 4 subtypes that does cause common cold symptoms. That is important because you wonder why some people will get exposed and have little or no symptoms. Almost certainly part of that is because they already had some of the other coronaviruses in the past and have an antibody and memory cell response to those viruses, okay? And we know some of this information from the prior SARS and also was the MERS, which was a related infection, right? Did they jump from horseshoe bats? The bats are not endemic to Wuhan, and the virus may have accidentally come out of the biomedical research lab. And there's a fast human-human change. So this suggests it's been out circulating for a while. Bats are mammals that live 25 years, tend to be in large groups, so there could be a reason why you would see some information from research about bats that could be helpful in this regard, right? And as with other predictions, this one would have been predicted. In other words, with influenza, we know that influenza tends to have a 9-year cycle. Once every 9 years, the strain will be a little more involved, a little more severe. And so with this particular virus, we also know that you will tend to have that kind of outcome with these types of viruses over time. So there was literature that was suggesting this, right? Hold on one second. Next, timeline. Okay, so I get asked these questions all the time about how this happened, when this happened, when it starts, something. So I just put it all on a slide, right? And I don't really find a lot of value in going through this, but again, the coronavirus bat sequences were deleted from a Wuhan database in 2019, and then there was a whole series of changes that occurred over time and then case reports, right? So we know that in the past SARS outbreak, 2003, 2004, it lasted 9 months and had about 10% mortality. MERS had a higher mortality, which by the way, that's why MERS was not a pandemic. Because in order to be a pandemic, it can't be that high of mortality. Because once you have such effective killing, it can't go across the globe, right? That's why the MERS was more contained, right? So best science right now, if you can call it that, is probably the gain-of-function research funded under Dr. Fauci, which was, always intended to be a, useful thing, probably got a little bit sideways, but it's hard to know that. I don't think we'll ever know that, but people always ask me these questions, so I just thought I'd throw it out there, okay? Next, I want to tell you about one thing. Influenza. Influenza mutates about 50 times a year. Corona mutates only about 25 times per year. Right? Which is why I want to remind everybody when we say we give an annual flu shot for something that mutates 50 times a year, you can understand why I'm going to have some comments about vaccines later where I'm not as supportive of certain aspects of vaccination because the mutation rate doesn't necessarily support that level of impact. Okay? All right. This is the model that you've seen of this. One thing I want to just point out here. If you look at the types of protein, remember the ESM protein, the nucleocapsid protein, the most specific and the most important is the spike protein, right? The S protein, right? So that's the one that's 10 times stronger at attaching to that ACE2 receptor, and that's the one that all the vaccines are generally really geared towards. And by the way, that's the one that is often used when you're doing the antigen testing, right? So we're going to be talking about that a little bit, right? Okay, rest stop. This is reading before and reading long ago. So we've talked about the virology, okay? I want to talk to you about epidemiology, okay? So this is primarily spread by the large respiratory droplets, okay? Now, I want you to keep kind of a couple things. First of all, what is a droplet, right? So this definition depends very much on what the resources you're looking at. So please keep in mind that when you're looking at this particular definition, there is a definition that it's greater than 100 microns. And some will call that inhalable aerosols, which confuses the discussion. But what I want you to keep in mind is this is primarily a droplet condition, primarily. Not solely, but primarily. So keep in mind that the droplets usually hit the ground within 2 to 3 feet, which is why when you had the distancing of 6 feet, I was questioning that distancing because by 2 to 3 feet, the primary mode is gone. And that's why, by the way, that the World Health Organization and the American Academy of Pediatrics said that 3 feet distancing was probably sufficient, okay? So please keep that in mind as to why there could be a difference in that. Next, aerosols, okay? So when you're talking about aerosols, so I tried to break this down for you into these different definitions, but these aerosols are the less than 5 microns, right? That's the truly aerosol or droplet nuclei that they call it, right? Those are the ones that go up into the air and hang around for a while. And there is a mechanism. By the way, a big researcher out of Brisbane was in Australia was advocating this and getting everybody to look at this, right? So aerosols can last longer. So the warning signs I always give people when patients are talking about, am I at risk? Is this the right environment? Should I be concerned about this? What I want you to keep in mind is that the smaller the room, the lesser the ventilation, the greater the risk of the aerosol. When you start getting to rooms this size and larger, then those aerosol risks start dropping a lot, okay? Also, there's engineering guidelines that can help with this, right? So I never knew much about this stuff, but I had to find it all out. So ideally, you want 8 to 10 liters per second exchange. And so you're going to say, well, that's a number I never heard of. Well, just know it. And then if anybody ever asks you, that's the truth. So if you're in an older building, for example, that doesn't have a good ventilation system, if you're in a closed room, if there's a lot of people, okay, now you're getting into a little bit more of a risk situation, right? So when patients are always asking me, should I go here? Should I do this? What about my family? So that's how I start to analyze that particular situation, okay? There are aerosols that have happened in buildings. So here's one. This is aerosols in China where they have these tall, high-rise apartment buildings. And they actually documented that the way the pipe systems were working and how the aerosols out of the pipes could go back up into some of the drains within the bathrooms. And that's how some people were getting infected at certain levels. So example, in this particular example, people at a higher floor up were more likely to get an aerosol infection. All right, so this can happen in these small closed systems, right? Okay, however, with aerosols, the biggest one I can think of is, remember measles, right? So it used to be that when a kid got measles, everybody would say, let's take all of our kids over there, we can have a measles party. You remember this? And so everybody get measles together and then everybody be happy that it's all over and stuff. Well, of course, now they say, you can't go talk to anybody who's got corona. So in a classic aerosol measles attack rate, you're going to get 85-90% attack rate, right? Corona is much weaker in that regard, which is why the aerosol is less of an issue, not a non-issue, but less of an issue because it's not quite as effective as that. When you look at the Delta variant, the Omicron variant, in the household context, about 20-30%. Now, just think about that. Think about that, right? So here you've got a supposed aerosol, which at times it is, right? But primarily respiratory droplets. And even in the home environment, you can have rates of only 20-30% conversion in the home. Fair? So in other words, what we're saying is that in the home environment, you would expect that if there's going to be a strong infectious component, it's going to be one that's going to translate very quickly into the other members of the household. But it's not true. It's not true, and you know it's not true. How many times have you seen people that said, well, this person got it, but the wife didn't, or something, you know, we see this all the time. And that's because it's primarily a droplet, not an aerosol. Also, the most unrecognized group for this infection is probably young males. First of all, you know, guys, you know, we're men, we don't test as much because we feel we don't need to do that. And secondly, there's a lot of asymptomatic carriage. Okay. All right, next. How much time? So take a look. Look. Look at those particle sizes, right? So the top one is normally the droplets. So look how quickly that goes to the floor in 3 to 5 seconds. Got it? So as you get smaller, more towards those aerosols, then it's going to hang up in the air. Right? So that's going to be some of the difference, right? The next thing is, one of the things that drove me absolutely berserk was this stuff about stay home, don't go outside, they close beaches, they close parks. That is the stupidest thing I've ever seen in my entire medical career, to tell people not to exercise, to isolate at home, become hermits, and don't get outside, don't exercise. First of all, this doesn't exist very long in the outdoors, right? Number two, UV light kills this stuff, right? Usually the virus, about 90% gone at 6 minutes, and depends on the type of light. By the way, there's even these germicidal UV monitors that can now be put into restaurants and business stuff, that if they're there, they could actually, you know, kill off any virus circulating in the area. So this is important to keep in mind when you're thinking about what is and is not a safe environment for people, okay? There's even the original Gesundheit chamber. This is how they used to measure this kind of stuff. This is from Fort Lee, and there were images. This is from the 1942 Jensen experiment, where they're looking at aerosols and what happens when people cough and sneeze and how the aerosols go up. This has actually been well studied in history, and that's where some of this information comes from about how to know whether or not something is going to be causing trouble for individuals, okay? This was a slide that got out in JAMA about a year and a half ago, and oh my Lord, everybody was like bent out of shape over this one. Okay, so a few things. One, this was a long-range turbulent cloud of sneezing. Okay, first of all, look, if you take somebody the size of Doug Martin and you ask him to go back and sneeze his brains out, okay, you can go out to 7-8 meters, right? I mean, you know, I'm not Doug Martin. I'd like to play him on television one time, but you know, I'm not that big, right? So they're getting on this huge thing, right? Number two, right? Where is this, right? If it's in a closed room with a lot of people with poor ventilation, then this is potentially an aerosol environment that we have to concern ourselves about. But a lot of this, don't forget, is those heavy droplets, the primary mechanism. And remember, I just showed you the data that this stuff goes to the ground fast, right? So that's why this is a little bit distorting as to the significance of that finding. Okay. So what happens, right? So you can see the clinical presentation. There's an incubation, then symptoms, and resolution, right? And then the transmission period, right? So look at that little difference here. Look. Look where you're going to see where you can start to have infectious period before somebody has symptoms, right? See how you're getting that start where the viral loads are going up, and you are infectious, but you don't have symptoms, right? And that's very important. Okay, next. Studies with viral loads. Okay, so first of all, this is on the stuff of surfaces. I'm going to show you this real quickly just to highlight some things. But first of all, I want you to know a couple things. I looked at these studies about the viral loads and surfaces. First of all, what these folks did in some of their experiments, they took amounts of virus that you'd have to get from an elephant, and they'd put it on these surfaces and say, well, is it possible? So everybody was like, okay, the FedEx driver is bringing you the thing to their home, and the box, what if they sneezed on the box, and the box is sitting there, and you touch the box, and then for some reason you're inclined to take every box that's delivered to your home and wipe it with your hand and then wipe it over your face because that's what you do every time you pick up a box. Okay, so I don't know who does that, right? But even in those scenarios where they piled it on there and tried to see what would happen to it, you saw drop-offs like this, right? So what I want you to do is just walk through this with me. This is SARS-CoV-2, SARS-CoV-1, right? The two different ones. The top one is the SARS-CoV-2. That's the one in the red. And you can see the time frames on the different surfaces. So copper, cardboard, stainless steel, plastic, and how they tend to drop off quickly within hours, right? But again, remember, those were large samples that were put on these surfaces in these controlled conditions. And for you to have transmission, you'd also have to touch those things and then put them on your hands and inhale them and wipe them on yourself. Things that are medically very unlikely to happen, right? Next thing, one more thing on this. I just want to point out to you. Notice the copper. Okay, so I just want you to notice copper. So the reason I bring that up is when people have said to me, Mark, what's the best mask to wear, if you believe in masks, then probably there's a couple copper-based masks that are better. That would be like Argamon in Israel has one, and there's a few others. The only downside is that they're no good after like 3 months, and they sometimes give a little bit of staining. But if people are asking me what's the best kind of mask, and the reason for that is because when viruses come into copper contact, it really is a very inhospitable environment, and they tend to degrade. Okay, contagiousness is also known as the R0, is the reproduction rate of an epidemic. Currently it's probably 2.5 to 5.5 because of the Omicron variant. Okay, so what does that mean? That means that for every person who's sick, on average, they will infect 2.5 to 5.5 people on average. That's with the Omicron variant, the variant we're in right now, because that one tends to be very efficient at transmission. Okay? Measles, by the way, for example, is greater than 10. Remember, we showed that, by the way. Right? We talked about measles parties. We talked about, 85, 90% attack rates, right? So that's measles ability, right? Now, that's without mitigation, okay? As soon as you start saying to people, stay home, don't work, socially distant, possibly put on mask, although mask wearing is kind of variable in its efficiencies, then that starts to drop, right? And so you get something called the HIT, herd immunity threshold, so that what that means is that if you can get that R0 less than 1, then a pandemic, a transmission, an epidemic starts to go away. All right. So if you look at some of the different variants and what was happening with them, there were these different predictions, right? Where the Wuhan variants seem to get about 60% of the population to go away. The Alpha variant jumped up to near 75%, and Delta went up to about 82%. Omicron, I think when the day is done, will be even higher than this, right? Which means that you'd have to say that if you're going to get rid of something, you have to have at least 80, 90% of your population to have had it, to get rid of it. So I want you to keep that in mind. When people start talking about, we're closing down and all this stuff, I have whole opinions on this kind of stuff. You have to keep in mind that in order to get to those levels, you're going to have to infect your population sooner or later in order to get rid of something. Okay? All right. Next, the problems with predictions. Okay, the Imperial College, which is Ferguson's work, these are the people that at the very beginning of these things, and still continuing, give all kinds of dire predictions, and say this is going to wipe out the planet, this is going to do this. These people are wrong. They were wrong before. Do you remember mad cow disease? The same people told us that we're going to have to cull the entire beef industry to prevent this stuff from coming. It never happens, right? Look, their data is flawed, and it's not held up. Why? Because individual susceptibility varies. People are in groups differently. People mitigate differently. It doesn't take that into account. Look. Do you remember Delta? Delta started where? In India, correct? Now, at that time, how much of those 1.5 billion people were immunized? I mean, a fraction of them, right? And there's Delta. It went away. Why did it go away? Did they immunize their entire population? No. Because this is the nature of infections. It comes in waves, it goes away, right? People change their behaviors, viruses change, they mutate, they don't quite find the same susceptibility they did before. People have certain variable levels of normal immunity anyways, right? So that's the way these things are. So it's not always the vaccine you're giving. It's not always the mask you're wearing. It's not always the social distancing. It is always going to be the nature of these infections, always, right? If you're looking at modeling predictions, then the one I think I like the best is the Reich Lab. They do a forecasting hub, and they look at different prediction models. I think if you're interested in that stuff, that's the one I felt was most reliable in this regard, okay? Now, let me show you another one, okay? So this is a little busy. Watch. Stay with me, okay? This says the following. Should I have a pointer? I need a pointer. If you have the coronavirus and then you shut down your population, okay, you would say that those people that take these serious steps of shutting everything down will have less infection. Correct? Fair? Whereas those places that don't shut down will have greater infection. Fair? Okay. So what you see here is that along the bottom there you see these different countries and different states and when they did or did not shut down. So the longer to the shutdown, the greater number of cases. Got it? So what you would expect is you'd have a line going right from that bottom corner up to the top, right? But that's not what you see. What you see is there were many locations that shut down quickly but still at huge rates. And there are other places that never shut down or shut down much later that had very low rates. So there's not good predictions from these same people that tell us what's going to happen and how it's happening, right? Okay. There's a cost to shutting down. I feel very strongly about this one. The data has been overwhelmingly against this stuff. And then for those of you that have bothered reading our book on workability and return to work, as you know, we have in the opening chapters discussions about the benefits of work. And when you don't let people work, every health indicator gets worse, right? That's just the way it is. We are all programmed as social animals to go punch a clock. That's just the way it is. And when we don't do that, we start getting in trouble. Divorce goes up, drug abuse goes up, physical violence goes up, all kinds of bad things start to happen. And so that's why I'm very much against those particular areas, okay? Remember, 1/3 of people will have no symptoms. So for all your, managing all this stuff and testing all this stuff, 1/3 of people have no symptoms and they're going to transmit, right? 60% of transmission comes from asymptomatic individuals. That's just the way it is, okay? So you may not like that. You may say, well, are you testing and doing all this testing? I'm not a big tester on a serial basis. For diagnostic purposes, totally fine. PCR is good for me, right? But otherwise, when trying to monitor people over time, it doesn't hold up, right? Okay, that's the epidemiology. We've talked about the virology. Let's talk about some of this testing, okay? Here we go. Right, so the nasopharyngeal test that we know about looks for the virus antigen at times or looks for the genetic material, right? So keep in mind, when you're doing the PCR test, you're looking for the genetic material, and I want you to remember something. That's the more reliable test. The other tests, the antigen tests, are good. They're reasonable. But they vary much more. And in particular, they've been weaker in the Omicron variant than all the variants we've seen up till now. So all those home testing kits are quite variable in how reliable they are. And by the way, I've seen this myself in my own patients, where I've had people say, I think you got corona. They say, oh, I did the home test twice. It's negative. So I don't care. It's just not reliable, right? The PCR is reliable, not 100%, but much more reliable. But the antigen tests vary. And they also vary depending on the variant, because the antigen tests are looking for some of those proteins that these viruses produce that have on their surfaces. But those particular antigens, those particular parts of the virus vary, okay? So that's why it's going to be less reliable, okay? Now, incubation period. This is particularly important if you're going to see any of these claims, to keep these numbers in mind at all times for yourself. The incubation period is usually 4 to 6 days. Omicron seems to be a little touch shorter, maybe on the order of as early as 3 days, right? But that's going to be the numbers to keep in mind when you're looking at the incubation period, okay? Next one. I always like to throw this at people because I think it's very helpful. There is some pretty good data that 97.5% of patients are positive nasopharyngally by 9 days after exposure, okay? So if somebody says to you, I want to know whether or not I have it, you can use that as a rough number, right? So you can say, look, if we wait about a week and then we test you, we will know with about 97.5% certainty whether or not you actually have it, okay? That's a number that can be very helpful when you're looking at reports, patients, or cases about what to think about. Next, viral shedding does not equal transmission, okay? Remember I showed you those little graphs about the epidemiology, okay? So remember, the virus shedding occurs 24 to 40 hours before symptom onset, right? Transmitting probably stops about 10 days after symptom onset. By the way, this is why the CDC finally brought some sanity, decreased their isolation to 5 days, okay? So a couple things. Please keep these numbers in mind. Please keep these numbers in mind. You are much more likely to transmit this in that 24-hour period before you actually have any symptoms. What is this?
Laser pointer, if you'd like it. No, this button right there.
Oh, thank you. I'd also like 4 new tires for my car. I mean, you know, what do you supply me? I just like, drug supplier, Fabrice. I don't know what kind of staff you're running here lately, Fabrice. But, okay, so now I have 2 things, okay, but, okay. Princess. Okay, so thank you. I don't know, should I put, maybe I'll do this one this way. Okay, all right, here we go. So, fine. So look. So we talked about the virus, right? So please remember, 24 to up to 48 hours before you get sick, you're going to be shedding that virus, and you're at practically the highest transmission levels you can be at. The first day of symptoms is probably the peak, and then it starts dropping, okay? So when you're trying to pin this down of causation, you got to keep those numbers in mind, right? And next, let's take a look at this. This is everyone. I like this pointer. This is good. Okay, so you see the asymptomatic versus symptomatic, right? The adult versus children, the chronic versus none, right? So what you're looking at here is what is the average time to the testing in the days, right? And so it shows you how you can have a big difference in if somebody's symptomatic, how long they can go out and test, right? Which is why I'm not a big tester after documented illness, because transmission is usually gone by at most 10 days, and these tests can stay positive for weeks, right? So if somebody is tested for diagnostic purposes, it's fine. But following them serially with testing does not make sense, because you're going to have positive tests with no transmission, because they're just leftover viral particles, right? The virus can shed but not be infectious at times. And next thing. This is a little bit technical, but I really want you to know this. You will be so cool to your kids if you do this, okay? Because I got a call from one of my kids, and he said, Lowell, they said I'm positive on a PCR. So everybody says, okay, that's it. That's the big time, the PCR test, right? Hold on a minute. The PCR is based on a threshold cycle count, which means that the way the test runs is to cycle through. And every time it cycles through, it's looking for lower and lower levels of viral titers, right? And as it's cycling through and it keeps looking for these viral titers, you can understand, well, if you keep testing something and looking for something, then eventually you're going to pick up something which may be the virus or it may be a false positive, right? So there's something called the threshold cycle count. And if you get a threshold cycle count less than 29, certainly in the teens or 20s, I'm going to say, okay, that's a true positive. But if you get a threshold cycle count that's getting up in the higher 30s, it's probably not true. And so when my son said this, I said, call your doctor and ask for the threshold cycle count. And sure enough, on cue, the doctor said, what is that, right? Never heard of that. So my son thought I was the coolest thing in the world at that. That's just for an hour, because it drops off very fast. They think my wife is cool all the time, but not me. Okay, so we called, and so the doctor said, so it came back to him, his threshold cycle count was 37. So I said, it's not true. You don't have it. And sure enough, he wasn't sick, right? They were just making this, do this random testing, all that kind of stuff. So keep that in mind when they're talking about the PCR, okay? What the NBA taught us, well, some good things, some not good things. The NBA taught us that there's a 3-day proliferative phase and 6 days until clearance. Therefore, 1% of NBA players were positive on PCR testing when they returned to play, and not one transmission was found, okay? So that means that if you keep testing these people all the time, right, they show that there is this proliferative phase where it goes up, but that you can keep testing these people and they're going to show stuff, but they're not going to transmit it, right? And that's what's very true with the NBA in their data set. Okay. Low respiratory lungs have more virus, but getting requires doing very invasive stuff. There are approval of the anterior nose and the mouth and stuff like that. I'm still right now a PCR guy, back of the throat, all the way to the nasopharynx. I always tell my patients, please open your mouth, look straight ahead, concentrate on your breathing. Your eyes are going to tear. I give them a Kleenex to hold, and then I go all the way back. I said, I'm going to be touching a part of your brain you didn't think existed, and they just go, whoa, you know, and so, but that's really, I think, the best way to do it. Remember, we talked about the threshold cycles. We also talked about the NFL also has stuff on that, right? Blood tests. Okay, the antibody tests, right? Oh, has there been a little bit of discussion about antibodies these days? Okay. IgM peaks 4 to 6 days. It starts appearing 4 to 6 days, peaks at day 12 and declines after 35 days, and the IgG, as you know, goes on longer. We know from the past infections of SARS and MERS that these IgG antibodies last for years. For years. I'm not talking about 4 months. I'm not talking about 6 months. I'm talking about years. I want you to keep that in mind when you see all this discussion about boosters and vaccines and all this stuff that's going on, that we already know how long these things are going to last. And indeed, we now have documentation for at least 18 months for sure on this current variant, okay? Here's the graph to keep in mind, okay? This is really going to help you when you're dealing with cases and claims of causation and what goes on, right? So you see here, the symptom onset is that black bar right in the middle, right? So what you've got is the virus is going on in there, and then you start having this increase in the virus, right? And you're also seeing that if you were to test somebody in these periods of time, you would actually pick it up, even though they have no symptoms, right? But you see that right here, the PCR is most certainly positive, and the transmissibility, see, so it's right up here, and really in those first few days, and it starts dropping off very quickly, right? So that's the time of greatest transmissibility, is when you're in that early part there, and then you start to see that the antibodies start coming out, right, and keep going out from there, right? And so that's the kind of the time frame to think about. But what you're going to see is this PCR likely positive, PCR likely negative, but look how many weeks you're going out. You're going out many, many weeks. That's why I don't do a lot of testing, because the transmissibility is so low of this period of time that's not giving you clinically meaningful information, right? So again, when you're looking at causation, and you have to look at the dates, you have to look at the time frames, you have to look at when somebody got tested to try to decide whether or not this is meaningful for this claim. Okay, next, on the testing. So I just want to remind you about the importance of pre-test and post-test probability. Okay, so remember this concept, right? Which is where we know this in particular, it's highly developed in the flu stuff, that depending on the symptoms someone is having in front of you, it influences how reliable the test result is, right? And that's because there's no perfect test. So depending on the test, so if you have a likelihood ratio of 15 in this example, right? If you have somebody that's in the middle of flu season has classic symptoms and you get a test, you've got almost 80% certainty it's true. But if you have somebody outside of flu season or with symptoms that you don't think is clearly coronavirus, right, then the post-test probability is very low. So even if you get a positive test, it doesn't necessarily mean it has it. You have to have that classic susceptibility to skepticism that helps you in trying to decipher and interpret what that means when you're evaluating these patients, right? Okay, variations in false negative rates of the PCR tests. So you can see that when you're shortly after days of exposure, right? Look at that, 7 days after days of exposure, that's the time that it's going to be most reliable, right? But you can see that over time, as you get going further from the exposure, you're seeing that the false rates start to go up, right? So that's why it needs you to interpret what does that test mean at this point in time. Because at this point in time is going to vary, and it's going to be different for you as to how you're going to interpret what this test means, right? Here's another way to look at it, right? Depending on the pre-test probability, right, that's going to influence how you interpret these. So if the pre-test probability is high, then the result is going to be high, right? So those are the way to think about those numbers. When you look at the drop-off of antibodies over time, you're going to see all these kinds of studies, right? So I just threw them out there. No big surprise, right? What you see is you go from 0, jumps up high, and then slowly can start to drop off. Now notice that slow drop off. Notice it is not to 0, right? When we start talking about vaccines and boosters, I want you to keep these slides in mind. You're not taking people from 0 to 100 back to 0, right? They're going up, they're having good responses, and then there's the slow, normal drop-off that we see in all vaccinations, okay? Another way to look at the blood testing, some more data on that, okay? Another way to look at the blood testing, some more data on that, just to show you. I've looked at this very carefully in a lot of studies. Okay, next. I cannot begin to emphasize how important these next slides are, because this never gets talked about. And I don't understand why. This should be front and center of every discussion. And that's the normal immune system that you and I are blessed with, right? You recall from basic immunology, the antigens presented to the macrophage stimulates the T cells. You get the cascade of T cells and B cells, right? And it's the B cells that produce the antibodies. But we also have the memory B cells, and we also have the T cells. That is the other half of our immune system. That is the part that ensures our long-term memory and protection. This is the one that's been shown to still work for decades after infection. I'm not talking a day, a week, a month, a year. I'm talking decades, right? They did some studies on elderly people who were around in the 1918 influenza epidemic, and 80, 90 years later, they still had evidence of T cell and B cell memory, right? That's why this is so important. Because when somebody's always talking about antibodies, I'm saying, where's the discussion about the cellular immunity, about the protection that that affords, right? That doesn't seem to fit conveniently into a narrative that a lot of people like to talk about, okay? Another thing I want to show you, okay? This is out of Shane Crotty's work at UC San Diego, very important lab. And what it shows is that when you have the coronavirus infection, that you get 100% T cell response, 100% IgG response. How many times in medicine do you see 100%? You know, almost never. So we know it's very good. What I want to show you is the following thing. They took patients who had never been exposed to COVID-19. How do I know that? Because they had blood samples from 2015 to 2018 for other studies they were doing. This is before COVID-19 ever existed. With me? They went and tested their blood. And what did they find? 50% of them showed T cell activity to COVID-19. Now you're saying, how's that possible? Well, I already told you how it's possible. Because the SARS viruses come from the beta corona group, right? The beta corona group is the ones that's responsible for the regular common colds, right? And so they have enough cross-reactivity. That's why lots of people don't get sick. That's why a lot of people can test different ways, because they've already seen this family of viruses, and they've already seen what can happen with that virus. And so that's why the T cells, the B cells, the cellular immunity is a central feature of how we defend ourselves, which is why natural infection becomes so important, right? Okay. Immunity happens by about 7 to 10 days, right? So here's the slides that look at those cellular cells that start coming up, and then they just last forever, right? And then years and years later, you can get that little amnestic response, which is what is happening for a lot of these people that have the regular SARS infection type viruses, right? Those beta coronaviruses that cause the common cold, right? All right. I guarantee the following about fatality rates. When they start talking about, oh, this is killing people, look, this is serious business. People have died, right? Don't get me wrong about this, right? But when you talk about rates, then you have to know certain numbers, which we don't know, right? Huge numbers have had this and didn't know it, right? Huge numbers have declined testing, right? The current range for fatality rates, if I had to put it, based on, this is probably the worst case scenario because Omicron is much better than this, is around these numbers, right? And so by comparison, you have influenza has a higher mortality rate than everything except maybe the nursing home elderly. Heart disease, much higher mortality rates. Cancer, much higher mortality rates. And so you have to keep that in mind, right? The next thing is one of the reporting things on this. So there's something called PIC, which is pneumonia, influenza, corona, okay? So what they ended up doing, as you may recall, is they started saying, look, we want all the hospitals to report their corona cases, which is fine. Number two, then they said, if you have a corona case, the federal government will pay you more. 3. They didn't say if it's a corona case that's caused the hospitalization. Is it somebody that's ill or dying from corona, or is it somebody that has an illness with corona? Got it? So I've already showed you that you can sample a lot of people and you're going to have a positive coronavirus test. But it doesn't mean they're infectious, doesn't mean they're transmitting, doesn't mean it's the cause of their illness. So all those numbers get very funny, right? And when they start talking about all the deaths in the country, right? No question it's serious business. No question people have died. No question, right? The question is, what's the true fatality rate? And did they die with corona or from corona, right? That's the part that's hard to know, okay? Antibody levels will be lower in asymptomatic individuals. Antibodies might drop quickly, even if reinfected. There's less illness. We talked about the durability. At 6 to 8 months, you will have about 25% of neutralizing antibodies. By the way, there are studies that show that you have 3% of your original peak of neutralizing antibodies, you are protected. 3%. Do you remember I showed you those graphs where the numbers shot up and the antibodies slowly start dropping off? Okay, 5% drop, 10%. So that is legions, years ahead of the benefits of most viruses, most antibody virus levels that we've ever seen, okay? 20% of antibody levels still give you 50% of protection, right? Think about those numbers. Think about those numbers. When people start telling you about boosters at 4 months and 6 months and all this kind of stuff, I just want you to think about those numbers, right? Okay. The lab methods used to claim efficacy for a vaccine have so much methodological variation it's hard to compare them. And then, you know, again, the memory cells are very important. And by the way, one more thing. The memory B cells will produce antibodies against new variants. By the way, if you have a natural infection, if you get the SARS-CoV-2 infection, not only will you have good antibody responses, you'll have good memory responses, and our immune systems are built in such a way that we will actually generate antibodies that can cross-react to other variants in the future. That's just how we're built, right? So that's why the natural infection has some steps up on vaccinations. We tend to adapt those antibodies, okay? There are some labs that can be used. I don't want to spend too much time on this. I think it's not important for the purpose of today's talk, right? There is some testing that's now becoming available that looks at T cells, right? And so this will be an interesting area that if people actually pursue this, could be helpful for us. And that's looking at labs that look for T cell responses. Okay, rest stop. Dad, why don't we get coronavirus? Because of the antibodies? Okay, so here we go. So we've talked about the virology, epidemiology testing. Okay, next. Let's take a look at some brief stuff on treatment. Again, the purpose of today's talk is not so much on treatment, but I felt like if I didn't do like one slide or something, you'd all, riot on me or something. So some good overviews. ACOM, again, we're going to come out with our next guideline. Please take a look at the ACOM guideline. Even the one we have out right now is very good on treatment recommendations, right? Anti-inflammatories, there was some talk about that. 4 studies show no negative effects of anti-inflammatories. But one thing I want you to know, if you take Tylenol or an anti-inflammatory and it's high dose, there is data that high doses of analgesics do suppress the immune system, okay? So high doses of anti-inflammatories or analgesics can suppress the immune system. So overall, what I try to tell my patients is just take the minimum amount you need to keep yourself comfortable. That would be helpful, okay? There was studies about the ACE inhibitors, the blood pressure medications having impacts on the ACE2 receptors, nothing there. Remember I talked about sunlight. The Z-Pak probably doesn't do much. Vitamin D, there was some good stuff there. about the vitamin D, about keeping your vitamin D levels a little bit higher. The vitamin D levels do seem to be protective. I do check vitamin D levels on all my patients when they come in for their annual checkups. And if I see a low vitamin D level, which by the way has become very common in the United States because one, we've become more indoor people, two, because the dermatologists have convinced us to protect our skin so we don't get so much sun conversion. So taking vitamin D can be helpful, and I do like that, I do recommend that. Fluvoxamine. We're looking at this right now because at first I thought, oh, come on, really? But it turns out that fluvoxamine probably has reasonable data that it can be helpful in treating this infection. And I'm not sure I completely understand why, but I have to be honest with the data, which is what always motivates me. Hydroxychloroquine had no difference at 14 days. However, there are patients, and I've had a few, that took hydroxychloroquine and they had a quicker symptomatic response. So at 14 days, there may be no difference, but there may be an earlier response that's better. Ivermectin, didn't see any good benefit. Colchicine, one study had decreased illness of civility, but is 4,400 patients, not sure. The monoclonal antibodies. So every single one of my patients that got the prior infections got on monoclonal antibodies. Turns out that the monoclonal antibodies are probably less effective for Omicron variant, probably less effective for the Omicron variant. And then there are the new pills coming on board, Paxlovid, Molnupiravir, and those two, I think, have good data, right? So that one would require that you have to work with a pharmacy. Walmart and CVS currently are the two that got the contracts to do it because it's going to be kind of controlled. So you'd have to have somebody with a positive PCR test and ideally within days. I think the cutoff's going to be like 3 to 5 days at most, but usually within days. If somebody has a positive PCR test and you're looking for a treatment for them, then it would be Paxlovid or Molnupiravir with ritonavir. Those are the medications. I gave you the dosages and usage on that. Okay, stop. All right, next. Oh my Lord, sorry. Here we go. Resources, forget about that. I'll try to limit my comments. Day 39 on the ARC, I thought there was a limit of 2, so you know how they manipulate. Okay, all right. Next I want to talk about what we started out with was we were going to do long haul or something like that, and then it just blossomed into all this stuff because you have to know all this stuff in order to be able to answer these questions and go through it, okay? So when you're talking about the coronavirus infection, you do have to break it up into different time frames, right? Because the big long haul area, the lake sequelae, depending on the source you're looking at, usually has little cutoffs. So this one uses 4 weeks as its cutoff. There's the acute infection, then the post-acute hyperinflammatory illness, right? And some of the changes that you can get with people, right? So post-acute is defined as greater than 2 to 3 weeks. Chronic defined as at least 4 to 12 weeks. And these numbers make a difference in the literature. So when people start asking you, if you're seeing claimants that are claiming long-haul symptoms, if they're having trouble recovering, you got to nail down what is the time frame that we're talking about because that's going to make a difference. Okay, about 65% of people are back to the usual state of health at about 7 days. And about 10% of you have persistent symptoms, but 85% of severes can have persistent symptoms for up to 60 days. So the severes are the ones that really usually require hospitalization, maybe ECMO, maybe intubation, IV steroids, something like that. Those are the group that'll do it. 88% of workers are back to work at 1 year. So there is a serious illness out there. There can be persistent symptoms, and that's things to keep in mind, okay? What's clinical features, okay? So this is the early phase, right? So this is the symptoms reporting in the early phase of illness, right? Next. This is the early late phase, okay? So you've got the acutes on the left side and the post-COVID follow-up groups, the lower ones, right? On 60 days post-discharge, greater than 50% of people had 3 symptoms and greater than 40% had lower quality of life markers, right? So you can see all the symptoms are dropping off, but the fatigue, the dyspnea, some of the joint stuff, that's still bothering people quite significantly later on, right? ARDS, not just COVID, does have a long time to take resolution. You can see diffusion capacity changes for up to 5 years after having this. But by the way, for my patients that have had pneumonia, For my patients that have influenza, I've said for years and years and years, you're not going to be normal for many months. They say, well, I got no fever, I got no cough, I'm not bringing up sputum. True. But you can still have persistent symptoms because that's just how our bodies work and that's how long it takes, okay? And in one of the data sets, for people at ARDS, which is, not just COVID, but the general group, about 50% of them are out of work at 1 year, right? Okay, so neurologic manifestations, okay? This is mostly the early phase, but this is some of the data in the literature, right? That you can get all the thing, and things people talk about the most obvious, the taste, the smell, but you have dizziness, headaches, you can have strokes, nerve pain, seizures have been seen, Guillain-Barré has been seen, myelitis has been seen, right? Early phase in this study, about 13.5% of all patients had neurologic manifestations in these different types of problems, right? More than 1/4 of patients, this is from the CDC, more than 1/4 of patients developed new neurological symptoms after the COVID-19 illness, right? About 25%, right? Clinical features between the two phases, you can see that there's a resolution that does go on, but you still have issues of dementia, mood, all different kinds of things that can go wrong in the neurologic phase, okay? Thromboembolism, right? Clotting, right? So again, early phase, you definitely see this in the early phase. Also on the lungs, you're going to see some of those changes in the lungs. This is, again, early phase, right? Then the early phase to death, this is the extensive fibrosis that you get in the lungs from those phases, right? Kidneys, this is called COVAN, COVID-associated nephropathy. This is usually an early phase problem that you can get. Early late phase in the kidneys, once again, what you're going to see is over time, you can see a drop-off. And once again, the ICU patients, the ones in the red lines, they're going to have more trouble, right? They're going to have greater loss of function, right? Cardiac. This comes up very importantly. Look. 78% have some abnormality when you study them, okay? 60% of myocardial inflammation. Do you see those numbers? Okay? This is important because this is an area that not just the natural infection hits you, but you're going to get hit in also the other areas of the condition, right? 3,000 college athletes, 0.7%, 21 had cardiac findings, right? And this is the early late phase. These are young, healthy folks, right? So you better be real sure that you're giving these people a vaccine for a very good reason, because you can get this stuff from the vaccine also, right? Right. Cardiac early late phase, another way to look at the data of how this came out from the American Heart Association, right? In severe hospitalized ICU patients, cardiac injury also has been seen from the virus, and in part reflects the ACE2 inhibitor receptors, which are also on heart muscle. And so, ARDS historically had those kind of numbers. MI risk doubled within the first 7 days of COVID-19 diagnosis. Patients who had MI and happened to also have COVID-19 had a worse outcome, right? So it is there in the cardiac phases, right? This is the possible causes that are looked at, and was one of the ways that you could test for that by doing different testing on a cardiovascular basis, okay? The long haulers, right? So these are the people that in the late phase start to have all kinds of troubles, right? So you can see the list there of some of the symptoms that people are going to get from the late phase, from the end of this type of infection, right? And there's even questionnaires you can give people looking at the late phase, right? And there are a lot of studies, right? I just show this to you to let you know that this has been looked at long and hard and continues to be looked at long and hard, right? 3/4 of patients hospitalized with COVID-19 had at least one ongoing symptom 6 months after their acute illness. So again, these are the severes, right? And there does seem to be a correlation that the more severe, the more you're going to have your symptoms, right? 1 in 5 patients not requiring supplemental oxygen had decreased lung function after 6 months, right? So they were in the hospital, not too bad, right? 26% at 60 days, 50% at 8 months. Another study had about 33% at 60 days with these types of long, late phase symptoms, right? Okay. COVID-19 function, right? How were you doing, right? So we talk a lot in our world about activities of daily living, right? So work life, social life, home life. Were you mild, moderate, or severe, right? And so you can see, again, that if you were seropositive and depending on where you were in these different areas, those of you that had more of the evidence of infection, more significant seropositivity, were more likely to have those impacts on activities of daily living that we care about in the late phase. So there's an overlap in the late phase between what somebody has, right? So some people have cognitive impairment, some people have psychiatric impairment, some have dysfunctional beating, some have different fibrotic lesions. These things tend to overlap into different groups, right? And depending on how you break it down, right, people are going to have shared symptoms across these different groups of patients, and that's what's going to dictate what their response is and what some of the things that you're going to see in those folks, okay? All right, so in workers' comp in California, they did an analysis of some of these folks, and what they saw was that if you looked at this group, right, and you tried to look at what % of them had troubles in the different groups, right? So again, most of the people, most of the people were mild, right? Much less in the severes, right? But if you also look at which one of those translated out into different problems and stuff, you started to see that there is, some persistence of symptoms and difficulties in these groups, right? California breaks it down into different groups based on the types of age group, right? So you can see that which groups have the largest numbers in them, right? So this is the 55 to 64-year-olds. And workers' compensation, obviously, you're going to see much more of a change when you look at some of the age groups because workers' comp tends to be a working population. Another way to look at the data, not to blow you away with that, but comorbidities, again, when you look at percentages of who had those different troubles, right? So sure enough, the hypertension, obesity, diabetes, those are the risk factors that you have to know about when you're doing these long phase ones. These are the mild COVIDs. Again, looking at what happens with workers' comp versus group health and how many of them go into trouble, right? And so group health seem to have more trouble than the workers' compensation patients, right? Mild COVID claims, again, those with incremental numbers, looking at again, 2 or more symptoms tends to drop off over time, and the one persistent symptom seems to be there, right? Again, California, the different looks at those COVID claims, how they break out, the severe versus the criticals, right? So, most common presenting symptoms we've talked about. Why? Why do people get this stuff, right? So these are some of the theories of why you may be getting these types of reactions. Why do people have this trouble, okay? So direct viral damage, you can get a cytokine response. The clotting could cause troubles to an organ system. That could be causing their symptoms, right? The low oxygen, when they were severely involved, could lead to some damage. Being in ICU, there are people that are called hardwired sickness syndrome. The brain focuses on the body energy source, does not turn off after healing. It doesn't turn off, and so it stays in that phase of a hardwired sickness, right? And certainly anxiety conversion disorders. One large French study showed symptom reporting may not be due to COVID. There is a large French study that said that the symptom reporting in the late phase may not be due to COVID, right? And that is something that we have to keep in mind. And also don't forget vaccines, which we're going to get to, okay? So these are some of the different mechanisms that are proposed for how these things get involved into the body and how these different factors can come to impact, right? Who's at risk for the long haul? Women, working age group, white people, lower socioeconomic, unvaccinated appears to be half the risk if they get the real infection. Okay? I want you to hear that number again. People who didn't get the vaccine but got the real infection seem to be half the risk of long haul. Okay? And then there's been documentation of a similar phenomenon way back from the Spanish flu and the Russian flu of a group of survivors that had long haul symptoms, right? One half who claimed they had long COVID had no evidence of infection. See that? They have a study in France where all these people were saying, look, I can't work, I can't do this, I can't do that. And it turned out when they studied these people carefully, one half of them had no evidence that they ever had the infection, right? This is a societal issue. This is sometimes what happens with well-intentioned systems to compensate people, to pay people not to work. This is the data, right? Whether you like it or not, whether you believe it or not, that's the data, right? Okay. Many discuss the fatigue of cardiopulmonary limitations, and there is something called POTS, which is postural orthopedic tachycardic syndrome, similar to sepsis stuff, and neuropsych testing may be of help. Treatment, like graduated exercise, SSRIs, nutrition, bronchodilators. There's support groups for this and some of the different mechanisms you can do that. Okay, rest stop. Those are the boys at the Panama Canal. Okay, so now I gave you, I think, all the groundwork except for the vaccines and variants, which I'm going to try to get to. But what I have to do now is walk you through the medical legal response to these things, okay? So what are the questions that you should consider having in your reports to try to help you in starting to approach patients that have claims of coronavirus causing long-term symptoms? And so these are sample questions that I want you to consider putting into your reports or putting into your questionnaires or having in your health questionnaires in your office intake for patients that are having claims of coronavirus, okay? Has the person you live with tested positive? Department of Health tell you to quarantine, right? California has specific presumptions, and you need to check with your state what are their presumptions, because most of them will have some that you need to know about in order to know what you're going to do, right? They're going to have time frames involved. When was your diagnosis, right? This California still applies through the end of this year. It has to be PCR positive, has to be diagnosed by a provider under physician. There has to be clear documentation of what was involved, and then there's a presumptions that if it's a healthcare worker, it's work-related. So you have to know in your state what are the presumptions, because unless you have some kind of uncontrovertible evidence that they were away from the work environment for at least a few weeks and that there was a known contact, that's going to be considered work-related. California also has employers can rebut this, so you have to know in your state what are the rebuttals to the presumptions for work-relatedness, right? And the law has some distinctions of who this applies to, which employers it applies to. You have to know in your state, right? Next, you're going to want to ask, do they have any of these conditions which places them at increased risk? You're going to want to know that, because if you're going to offer an opinion about whether or not something's work-related or it's causing their long-term troubles, you have to know, did they have these conditions, because that impacts what you're going to say, right? So what we did in one of our papers is we gave you clinical scenarios, right? And we just outlined different scenarios of how to look at this stuff. In particular, we talked about different scenarios that you could think about for how to break down patients, how to approach the patients, how to understand the patients, to decide how you're going to approach them, right? And so the very simple ones are very straightforward, right? But then we start to get into clinical scenarios of pre-symptomatic, and those people, again, tend to be relatively easy to handle. There are individuals who test positive, have mild disease. They're not hospitalized, right? They were never significantly dyspneic. Their pulse oximeter stayed normal. And once they recovered, they're asymptomatic. And you may need to wait up to 3 to 6 months. And you might need to do some testing, right? When you start getting a little more involved, moderate disease, they're positive, they're hospitalized. They sometimes got supplemental oxygen. They had abnormal chest x-rays or chest x-rays. Okay, now you're going to want to get those records, right? And look at them carefully and objectively document anything that they're saying, right? Whether it's the back pain, joint pain, chest pain, shortness of breath, headaches, fatigue, cognitive function, that's when you're going to start documenting. Scenario number 5, when you get more severe, right? They're in the ICU usually. these cases almost certainly, by definition, will require pulmonary function testing, metabolic stress echocardiogram, along with other areas that are involved. And then number 6, the last one, these are the people, all the worst. They actually had heart failure, heart attacks, dysrhythmia, stroke, renal failure, psychological illness, coagulopathies. You got to look through, you got to test them. And these people take months to years to be at MMI, right? Now, nobody likes that, right? Lawyers don't like that, they don't get their money. Patients don't like that, they don't get their money. Employers don't like that because they, open-ended claims. Insurance companies go nuts over this. But that's the truth. You got to wait a long time on these people to determine what you're going to do, okay? This is the Activities Daily Living Questionnaire that I wrote. This is published in JOEM. And so I don't care what Activity Daily Living Questionnaire, I got a whole nother talk on Activity Daily Living Questionnaire. All I'm going to say is you have to have an Activities Daily Living Questionnaire. I don't care which one you use. You can use mine, you can use somebody else's, you can use your own, but you have to have an Activities Daily Living Questionnaire when you're doing these evaluations to know how to answer how they're impacted, okay? Testing. We've talked about some of the things you have to do and how you have to wait on a lot of these things, and then the guides. So this is 5th and 6th editions, right? So there's different pages and tables where you can use. So for cardiac, these are the recommended areas that you go to, right? Neurology, there are the reports of Guillain-Barré. ENT, the smelling one, that's also in there for you. Hematology for the hypercoagulables and people that had little bits of clotting. Then certainly mental behavioral disorders, the psychiatrics. And a lot of times what I'll do on these patients that have persistent symptoms is I will get a neuropsychological evaluation. I will get a neuropsychological evaluation to try to help me through that, okay? What's the length of disability? This comes from the MD guidelines, right? About, this is one of the tables that we wrote about how long you could expect somebody to be out of work, depending on their type of work, and this is the average numbers. So you see we gave it up to about 2 months. People that do very heavy work to be out of work. If somebody has a sedentary job, that's about 3 weeks, right? So please keep those numbers in mind when you think about what's reasonable time, where you can use the MD guidelines as your reference, where you're giving recommendations about workability and return to work, to use those numbers, right? Okay, summary. Dietetics and weight loss are important. See your doctor regularly. Get a flu shot every fall. People sometimes forget that right now. Who should get a vaccine? We're going to try to cover that in the next talk. Prayer is very important when you're doing all this stuff, and I'm pretty sure I have no idea.
Okay, so we have 3 questions from Hoover. So Dr. Hyman, what do you mean by you can get this stuff from the vaccine also? And I think that was a slide on the cardiomyopathy.
Yeah, we're going to cover, hopefully now, if you guys are not sick of me, we're going to cover vaccines and variants now, and that's why I tried to point that out, because we're going to be getting to that.
Okay. A positive antigen test, does that mean infection or exposure? Or false positive? A positive antigen test, does that mean infection or exposure? Or false positive?
Yes. I'm dreaming, so I'd ask, who's the patient, what's the symptoms, what's the time frame, what's my exam, what's the likelihood, do that likelihood ratio of like, okay, and then try to interpret it along those lines.
Last question, are you saying the risk of long haul is higher in the vaccinated people?
No.
Thank you.
Okay, if I could have my other slides up. Here we go. Okay, thank you for tolerating me this much. I'm going to try, we're supposed to end at 1 o'clock. I'm going to try to get us there. So please understand, my goals are really, there's so much here, and as I told you, there's things I'm not covering. I'm not covering the whole masking world. I'm not covering schools and kids and education. There's just so much time. But I want to try to get to as much of this as I can. And so I'm going to flip through some slides at the beginning just because it has my usual disclosures, and I apologize for that. Don't stand there and be hungry. Come on in and get fed up. So that's in the restaurant window. So yeah, I hope you're not fed up with me. Okay. people I have to thank for. Here's 3 of my boys at one of our little gatherings together. The books we've already talked about, so thankfully I don't have to go through all the articles again. So that's it. Okay. All right, vaccines. So there are 4 types of vaccines. So please keep that in mind when we're talking about vaccines, right? This is really important because when you're talking about vaccines, there are different types of vaccines and different ways they're formulated, right? So one of the good things about this stuff is the following. The mRNAs are new, but obviously this is research that's been going on for decades, right? And so there is obviously a hesitation about the mRNAs because they're new, and I had some of that hesitation also. And I still think that the full information is not in yet. On the other hand, the mRNA technology and research has been going on for decades. So it's not completely as new as it may seem to us. Secondly, I think I have this at the end, but we'll talk about some of the procurements and how this came about, right? So if you look at the literature, they'll tell you about the different companies and where they're at in their development processes. Are they EUA, are like the great Pfizer BioNTech, which is now fully authorized. And we've got 9 out there, 3 approved so far. Novavax is modified protein. Others are the mRNA or the inactivateds, okay? Okay, next. If you remember nothing else about everything I said today, please remember this, okay? Vaccines will prevent disease. They won't prevent infection. They won't prevent asymptomatic viral shedding. They never will. They never have. They never will in the future. I guess you say anything's possible. Okay, anything's possible, right? But, you know, this is reality. This is fact, right? So for all your friends and patients and family members who are now hermits and who believe that they cannot face the world any longer, right? You need to bring them to the Lord and say, listen, it's always been this way. It's always going to be this way, okay? There's always going to be illness. There's always going to be disease. There's always going to be things you can control and you can't control. We've talked about the asymptomatic transmission, right? We've talked about that infectious period even before their symptoms, right? So we know that there's only so much we can do and expect from all the things that we do as interventions. And it would serve us well in medicine to have a little bit of honesty about what we can do, what we can't do, our limits, and what we do and don't know, okay? When we're looking at safety, there are 4 systems in the United States to look at safety, okay? So these are the 4 systems that look at that for COVID-19. So VSafe, this is an interesting system CDC has where people volunteer. And what they do is they say, okay, I'm going to take a vaccine. I'm going to sign up on your little app. And then if I sign up on your app, I'm going to get these little things that come to me. And I fill them out. And I say, okay, yes, today I'm having symptoms. And this is a nice little way to kind of check. Now, this obviously requires people to be actively involved, people that are trying to be participatory and helpful in noticing what is going on with their symptoms and problems after VSafe, okay? Number 2, VAERS. This is the one that's probably talked about the most, the early warning system, right? And it's co-managed by the CDC and the FDA, okay? So the strengths versus limitations. The strengths. It can rapidly detect safety signals because with VAERS, you can get anybody and everybody to fill out a VAERS report. So somebody says, well, that's it. You know, my toe turned blue. It must be from the vaccine. It's not that I hit the table, because I've hit tables before with my foot and never turned this blue. Okay? So they can go fill out a VAERS, and they can say that's what they think, right? Now, that's not necessarily COVID toes, but it is their report. But you could see, with a broad net, you can gather a lot of fish. And then you have to start seeing, are there a lot of fish of the same type in there, right? And so the downsides, it could be reporting bias. Who fills these out? By the way, the VAERS system is not easy and automatic to fill out. You got to go on there, and if you don't fill out things, it like shuts down after 15 minutes or something like, you know, it's like, you know, and who's willing to take the time? So there's all kinds of biases involved in that. And then you don't have unvaccinated comparisons because people who have not had vaccine don't go to VAERS. But somebody who stubs their toe, gets a blue toe from hidden table, they're going to get some of the same troubles, but they don't report it to theirs, right? So you don't have that comparison group that you're looking for, okay? CISA, number 3, the Clinical Immunization Safety Assessment. So there's these participating centers. The only good thing on this is that since they did not have the University of Michigan, they also don't have Ohio State, which makes me very happy. Okay, so with the CISA project, they do look at these centers where they have experts that look at vaccine safety. And these are people that are in these centers that are looking at the data and coming out with ideas, fact-finding, trying to put together information for the government, and that can be very helpful, right? And the VSD, the last one, Vaccine Safety Data Link. There's 9 participants, and so this is a lot of the Kaiser system in particular, where they have huge numbers, right? So the big advantage of the Kaiser systems is you have huge numbers. So they can do coding within their systems, and they can look at that. And what they do is they link the data between all the different charts and computers to try to get you an idea of what's going on, okay? An important example of the heck, what happened to that one? Okay, on the safety ones, Klein did a study in JAMA looking at 10 million doses and found no data for any increased risk of any serious side effect of vaccine. Okay? 10 million people, it's a lot of people. JAMA, it's one of our top journals. No side effects, okay. Zoo looked at 11 million people, and the vaccines helped with all deaths, and not just COVID. For some reason, this is the vaccine panacea, right? And then Jabagian in JAMA did a study in France of age 75, and I'm sorry you can't read it, but that was doing the Pfizer mRNAs. 14 days after injection, they had 3.9 million people had at least 1 dose, and there's no increased risk of trouble. So you say, hey, these are the greatest things since sliced bread, right? Sign me up. I'll take a few extras. What the heck? Yet there are side effects, right? Guillain-Barré was seen with the Johnson & Johnson product, about 6 to 8 in 100,000 people. The vaccine thrombosis troubles have been seen, particularly in J&J. There's something called a skin-Jones-Moat reaction, which is where you slough off your skin. Anaphylaxis has occurred in myocarditis. By the way, there's a new Kaiser study that just came out, I think, 3 days ago. You think I'm kidding how hard I work for you people. These slides were redone last night. I mean, this is how much this stuff comes out. The Kaiser study had 1 in 3,000 had myocarditis. Remember we were talking about the sequelae of COVID. Remember we talked about the cardiac system, right? Remember we talked about that? The MIs, the myocarditis, pericarditis? And I said, we're going to talk about that in the vaccines. I think that was one of the questions that Fabrice brought to me. This is one of them, right? That you can actually see this type of inflammation in the heart, right? Right. Characteristics of the clotting. The median age is 44 and a half years old. Females predominated. Tend to be younger females, right? This was by comparison with past COVID infection. There was no prediction from the past COVID infection. It seemed to be directly related to the vaccination, right? Who's at risk for the clotting? Those same risk factors. Remember we talked earlier about if you're doing an evaluation, please make sure you take information in about what is the past history of this individual, right? Because that's going to put people at risk for these particular troubles, so please know that, right? In the Janssen product, right, as of December, they had, comes about half a person in a million gets the clotting, and that's important to know about. Females in the middle age groups had the highest rates, right, of this clotting problem with the Janssen product. Again, by the way, I'm going to say this again. Females in this middle age group, okay? Now I'm saying that again because we're going to be talking about boosters, right? I'm a big vaccine person. I believe in vaccines. Everybody should be vaccinated. That's not my issue, okay? My issue starts to become what happens when we start talking about boosters, okay? That's where my issue starts to happen, okay? And what's the benefits and risks in the women, right? So the benefits are over here on the left side, right? depending on your age group, and as you get older, you get more benefits statistically. But also, there are these risks of myocarditis, inflamed heart, and Guillain-Barré syndrome, which is that neurologic disruption that's very worrisome, right? It happens. It happens with the vaccine, right? So you can say, well, Mark, I think that there's a huge benefit for these vaccines. Well, that's true. It's particularly true when you're older. But it's less true, still true, but it's less true as you get younger, okay? So please keep that in mind, right? For the men, similar types of data. Take a look at that. By the way, you know, in the men, right, you start to get this stuff of the myocarditis stuff. You see that? See that? So you say, so I was telling you before, look. 1849, so in this data set, right, you got 3,000 had myocarditis with the infection. You had 13 with the vaccination, okay? So I'm not saying that real infection is a walk in the park. I'm not saying that, right? I'm saying people have had serious troubles. I'm not done it. It's clear. But as far as the things we care about, death, right? Severe disability, right? I've got to know that it's particularly as you get younger, that it's really worth the risk that I know comes with these vaccines to give them a shot, okay? All right. Myocarditis after mRNAs. This is the mRNAs. At 3 months of follow-up, there was no confirmed deaths, right? Clotting was seen, and Guillain-Barré was also seen. And 10% of those people with the COVID-19 vaccine required mechanical ventilation after the vaccination. Okay, 10%. Okay. V-safe participants. So this is one of the systems. Now look. I want to show this to you. Look. 5 to 11-year-olds. 5 to 11 years old. Okay? And this is the number of doses that they were being studied, right? Out of about 7 million administered, right? And what you saw was that as you look at the numbers as they go up, right? Males, females, and who you're not sure about, of the dosages, how they were administered to different groups, right? And what was the side effects, okay? So again, fever, vomiting, chest pain, C-reactive protein, but all of a sudden you come down here and you got your echocardiogram normal change or a troponin increase, right? Intensive care, right? Seizure, right? You better tell me that I'm giving these young kids an mRNA vaccine for a very good reason, because I know that if I give them a shot, there's a risk of trouble, right? This is a discussion we all need to have openly. I'm not saying not to give them a shot. I believe everybody should have a vaccination, and I think it's reasonable for the kids to have vaccination. But if somebody says to me, why am I giving my kid a shot? And I say to them, it's because they live with their elderly grandmother. It's because they have a parent that's immune deficient. It's because they're trying to participate as a citizen and decrease the risk of transmission in society. That's a better statement than say, I'm protecting them. Whoa. What's the data if they get the real infection? Well, the data with the real infection with the kids overwhelmingly has been not a big issue. Overwhelmingly, right? Now, Omicron has shifted that a little bit, right? Influenza is not like this, by the way. Influenza is not like this, right? Influenza is an illness of the elderly and the young, right? Not this coronavirus infection. It's overwhelmingly an infection of the elderly. Overwhelmingly, right? So I've got to know that I'm doing this for the kids for a very clear reason, right? And we already talked about, remember I showed you the data about transmission, right? 60% come from unknown, asymptomatic, all that stuff, right? Overwhelmingly, kids and young adults are asymptomatic anyways. So I really want to know, am I giving it to them for a very good reason, right? Okay. Verified reports of myocarditis in children ages 5 to 11. There are reported 2 deaths. Okay? Now, this is out of millions of doses. So you could say it's very rare, true. And all I'm saying is, how many of those kids would die with the real infection? And up till now, Omicron shifted a little bit, been almost non-existent. Yes, you say, well, I heard about kids in the ICU, I heard about this. Yes, but a lot of those people were either unvaccinated or had pre-existing conditions, right? You have to know what's operating, right? Top 5 solicited reactions reported by children in the young age group. And so you can see the things that, okay, I'm sorry if you had a little pain, a fever, a fatigue, I don't care. You know, life's too short for me to listen to this stuff, right? You know, get on with it. You know, it's okay. You know, you kids, you know, it's okay. You can have a little bit of upset in your life. This is not a rosy picture for you, right? That's not what I care about. I care about those serious things, right? Okay, this is the variants that we've talked about. The bigger ones, Delta was the biggest one until Omicron came along. And then when we look at the variants, the Omicron, this study was, just to give you a perspective how quickly these things go, from the second quarter to third quarter of last year, Omicron was, 2.9%, right? Just shot up, right? It's now at least 89%, right? So that's transmission city, folks. I mean, I'm from Detroit. That's transmission city. But that's transmission, right? And you think like you're going to, it's like, oh, I got the right mask and I'm washing my hands and I'm wiping down the surface. Are you kidding me? You know, this thing's, it's laughing at you all the way, right? This is transmission, right? All right, efficacy. If you look at the mRNAs in preventing COVID, this is in preventing COVID, you see curves like this, right? Vaccine efficacy, and we talked a little bit earlier about vaccine efficacy, how it varies between labs and over time. But you can see typical things like this, where the bottom line is people that got the mRNA vaccines versus people who took placebos and what the incidence rate of getting infection and stuff. And again, it works. There's no question about it. Some of the best things we've ever seen, right? Cumulative incidence of COVID-19 outcomes during a period of marked alpha variant predominance. I want to tell you one thing. Wait. I want you to remember something. These studies were done on the alpha variant. Some of the studies were done on the delta variant. No studies of substance have been done on the Omicron variant. This is very important because the efficacy and how well these things work depend on which variant you're talking about, okay? So I'm not saying it doesn't work. It's great stuff, right? This is for documented infection, for COVID-19, symptomatic COVID-19. This is looking at hospitalizations, ICU admissions. It does well. Does well. Both of these things do very well, right? No question about it, but it's still based on the different things. Second, the reason I brought this slide in, people, my patients, everybody, I get calls from all over the place. Which vaccine should I take, Mark? Should I take Pfizer or Moderna? Or what do you think about Johnson & Johnson? I had the Johnson, Okay, so in general, it's way more important to have a vaccine than no vaccine. Second issue is I do like the mRNAs more than the others, both from a side effect profile and from efficacy rates. And then if, you really held my foot to the fire and said, which one would you take between the two? I'd say, I'm not going to tell you online, but I'll tell you privately. Okay, next. Estimated vaccine efficacy against laboratory confirmed. So what you'll notice here is this is a very important slide. The first column is the BioNTech. The second one is the 1290, that's Moderna. The third one is the 80, that's Johnson & Johnson. And so you can see that the efficacy on all these depends on your age group. So younger age is at the top, middle age next, and the elderly at the bottom. And the efficacy can vary over time depending on what variant is circulating, right? And so that's going to dictate some of that response. But all of them, I want you to know, all of them have very good efficacy. They're good shots. The mRNAs are, in particular, are very good shots, right? Okay, little busy slide, I know, but I'm trying to do the variants for you with Mu. Remember that one got kind of blasted past, I think, a little bit because everybody was on to Omicron before we had it's just day in the sun. And so this just looks at the epidemiology. This is from Columbia, and it was looking at the serums and stuff, and then it turned out that Delta, as compared to the alpha, which is the first one we knew about, is twice as transmissible, and it gives you 1,000% higher viral loads. And so what you're going to see is that over time the variants vary in how much efficacy they have, and also how prevalent they are in the society. That's something to keep in mind when everybody's talking about, do these vaccines work? Who do they use them on? What should you be using them for, okay? So if you look at a typical study, it's going to say, look at our great product. Vaccine efficacy against severe illness, 97%. Wow. We've never seen numbers like that ever in vaccination, right? These are some of the best vaccines we've ever seen in vaccination, and brought about great results when you compare the placebo versus the BNT. You know, really good stuff, right? And again, different places have different controls. Now, one point here. Wait, this is very important. Really important. Wait. Don't, look at this. Intervals, right? So it turns out that it's probably better that if you get 2 shots of the mRNA, the further apart you get them is better. So if you followed the original recommendation, usually, what was that, 3 weeks or something like that? Well, you know, so so there's a funny thing. There's the great things like cornflakes, how that get discovered. Right? I'm from Michigan, so we know these things. So anyways, so if you had a country that was low on supply, they couldn't give the mRNAs as frequently as recommended. That happened in the UK. So they started spacing out 4 weeks, 5 weeks. Well, guess what? Then they did follow-up studies, and the people that had longer time frames between their 2 dosages actually had better vaccine efficacy, right? And this is also going to come up when we talk about the boosters. Okay, so why are there boosters, right? I just showed you this huge vaccine efficacy, numbers you've never seen before in regular vaccination, right? So why is the world after boosters, right? All right, so let's first look at some real infections. First of all, I told you in the earlier talk, and I want to remind you about this also, very, very important. In the earlier talk, we were talking about how people don't talk about the cellular immunity, they talk about real infections. So look at this important study from New England Journal of Medicine. This is people in Qatar, and they compared people who had their first infection versus people that had reinfection. So these are people that never had vaccines. People who had the real infection did better, okay? People who had the real infection did better. They had 4 that had severe disease, nobody critical, nobody died, right? That is the benefits of the real infection. And no vaccine is ever going to match that, okay? You don't like it? Tough, right? You think that you're God and you control the vaccine world and everything's going to work out perfectly. You're wrong, right? There's nothing like a real infection, right? And that's just the way it is. By the way, okay, since I'm running so late anyways, it doesn't matter. So you know, why is there such an uptick in asthma, inflammatory bowel disease, diabetes? Part of it is because there's very good data now that we were so busy sterilizing our environments that our immune systems got so bored that they had nothing else to do that they started having troubles with autoimmune disease. That's why, that there's an uptick in this thing. So sometimes when we sit there and we try to sterilize environments and take vaccine, there's something about real infection. There's something about telling kids to go out and play and groveling in dirt that helps, okay? Right. Israel. So we owe great thanks to Israel. Israel has really been on the forefront providing incredible data, and I'm very, very appreciative of that. There's no question they've been terrific at this stuff, okay? The problems. The data from Israel had higher breakthrough rates that were different from other countries for some reason, And they did these retrospective studies on their population and said, okay, we think there's a drop-off, right? And what they started to show, like here from the Mayo Clinic system, is that over time, now this is over a number of months, there seemed to be a little bit of a drop-off in what they thought was their vaccine efficacy and the levels of the antibodies, okay? So you remember I told you that there's going to be a drop-off in antibody levels. There's no question about that. The question is, does that drop-off in antibody levels make a difference, right? Remember I told you that you just need low levels of antibodies, and we're still not talking about the cellular immune system. We're just talking about antibodies again, right? Okay. So, despite high vaccine efficacy, vaccine breakthrough cases are expected, okay? This will be caused by variants, and we'll monitor that. In August, there had been 1,500 deaths of reported back through infections, but already I told you that part of the problem with some of the death data and the hospital's data was, did they die from corona or did they die with corona? Again, that's going to influence that data very much, right? And the vaccines do work on the variants. And a vaccine is 90% effective, you still have to vaccinate over half your population anyways, right? Remember we talked about the herd immunity before? So you got to hit very high numbers, otherwise this stuff is just going to transmit in waves and just get over it, because that's what's going to happen, right? Studies have shown that those with natural immunity do have equal, if not higher protection than those never infected. In a natural infection at 6 months, there's a little difference in outcomes and you have more diverse antibodies. So a natural infection does have an advantage. Fully vaccinated people does provide additional protection from reinfection. So I do say to my patients, even if you have the natural infection, do take the original primary series. Again, I'm totally supportive overall of the primary series, particularly as you get older. There's no question about it, right? Chinese vaccines don't work quite as well. CureVac is less efficacious, but if that's all you got, that's all it does. I was wrong on one prior recommendation. When the outbreak, when the pandemic first started, and I was looking at the vaccine research, I said to some of my young ladies, I said, look, why don't you wait for the Johnson & Johnson product when that becomes available? It's only one shot. It's based on older technology. And that was wrong. I think that the mRNAs have really overtaken, in particular because of the side effect profile. If you wait longer, we talked about that. That seems to be helpful. And it's normal for the antibodies to wane, which is why T cells are key. I can't say it enough times. I'm going to keep saying it because nobody talks about it in the newspapers. Nobody talks about all these proclamations. The CDC doesn't talk about it. It's madness. Madness drives me nuts. Okay, cold storage is modified, so that allows for this to get out more. You can wait after infection to take the vaccine if you haven't had the primary series. 20 days if you're mild, 90 days if you're severe. In one study, in 4,500 patients, the odds of COVID-19 hospitalization were reduced to 0.15 and death to 0.33 in those vaccinated. Also the studies, 20% of hospitalized were immune compromised. And again, we talked about the French study. Chinese vaccines, sorry. Okay, positives in kids. Okay? If they get a vaccine, there's less infection severity, there's less transmission, more likely to encourage educational continuity, which, by the way, should be the #1 marker for whether or not kids should get this thing, because it's way more important for kids to be in school than anything else. There's less kids studied, though, and the dosages are smaller. By the way, some people who say to me, okay, Mark, they're making me get a booster. I don't want to get a booster. I say, okay, then go in there and tell them that your doctor says that you want the kid's dose. It's less, so we can do it that way. All right. In kids less than 12, you're more likely to have a negative outcome from the vaccination from the natural infection. We talked about that, right? The myocarditis risk, we've talked about that. We talked about some of the data in kids and hospitalization. Either way, the risks are pretty low, right? So when you're evaluating the BTN, they have this study of 2,300 kids. They showed 90% efficacy. So that's in the New England Journal, just came out, I think, last week. So remember, kids, 1961, what's the meaning of these marks? What's the meaning of these marks? This is the way the world has changed. And so we have to realize that the world's changed a little bit, but doesn't change the data and the recommendations, okay? Overwhelmingly, deaths are due to the unvaccinated. Peltzman effect is active, which means people change their risk behavior after a shot. So you need to know about that. Many people do this. People put on a seatbelt and say, I'm going to drive my car like a wild man. People get on their motorcycles, put on a helmet and say, that's it, I'm free to go, right? That's a Peltzman effect. So people take a shot and some say, okay, now I don't need to mitigate or do anything, and they change their behaviors, right? So that can influence some of this data about what you're looking at, right? In Israel, the mRNA with Pfizer, we talked a little bit about that, but there are some problems. Breakthrough infections do occur in healthcare workers. And so depending on the data that you're looking at, those are real issues about getting side effects from these vaccines that you have to be honest about. It's overwhelmingly, remember I showed you the graphs, about the benefits versus the side effects. No question about it. But the data is strongest in the elderly, right? If you looked at the third dose, the booster dose, they broke this down, and they did have lower rates of severe illness. And they will tell you, everybody will tell you, you will see this number again and again thrown in your face. There was a 10-fold reduction. Okay? You're going to see that number? Yes. But if you start with 5 million people, and the number of cases in each group is on the order of 3 to 20,000, the confidence intervals on that statistics gets very wide. Okay? Number two, this is a limited population ethnically, right? The additional health behaviors, the Peltzman effect was not studied, right? And the follow-up in Israel was 54 days. It was 54 days, right? And I'm going to show you why that's important a little bit. And when you say you got 10% reduction, yes, they went from 99% to 90% in their study. Well, okay, that's a 10-fold reduction, but this is still in the 90% range. This is still better than virtually any vaccine we've ever had in the first place, right? They also, in their study, had known risk factors which were not associated with deaths. We know from all the other studies that if you have COPD, diabetes, or heart disease, you're going to be at risk for death. For some reason in Israel, that wasn't the case. What is it about that study and their population that's so different, right? And they were studying Delta, not Omicron. And later, was it with COVID or from COVID? Okay? So, you look at this and everybody say, go get a booster, right? Because the top is no booster. The bottom is a booster, right? Say, look at those efficacy rates, right? But if you look at the data carefully, what do you find? You find that any of the benefit was in these groups right here, right? So that's why I put a blue box around it. I know it's a busy slide, but I just want you to know, I know it's hard to see. But the benefits in their study population were all people in their 60s, 70s, and 80s. No other group. Okay? Oh, crap. Sorry. Okay. I got so much to tell you. I can't. Okay. So I'm going to go really fast because, Fabrice is like never going to invite me back. Okay. So this is the group that got the benefit, right? So I don't have a problem necessarily with an elderly person with risk. But boy, oh boy, you start telling me to start boost the entire world over this data that went for 54 days, I'm not sure, okay? Had enough yet? How about fourth dose? The French group doing it with kidney transplants, Israel doing a little bit, and there's a bump in there, there's no surprise, but where does this end, right? And they admit, even in the studies, they're now starting to say, but we're not talking about T cells, we're not talking about B cells, we're not talking about cellular immunity, it's a problem, right? There was data that 83% of Americans have had some antibody evidence of infection. The vaccines may help prevent long COVID. That's interesting. We talked about the dosing intervals. Here's a study. I just got to do this. I got to do this, even if Fabrice never talks to me again. Okay, look. This is really important, okay? You say run and get a booster. I say look at these two main mRNA vaccines, look at the protection, and then look what happens after 90 days. 90 days after the immunization, people were more likely to get the infection. The efficacy went from positive to negative, okay? So this is the kind of stuff that you don't see, right? But this has been well discussed and talked about now in the literature, right? There will always be antigenic shift. This is endemic. Folks, get used to it. It's always been here. It's always going to be here. It's been more severe. It's been less severe. And just remember, don't forget, it is in the virus' best interest not to be lethal. Because lethal kills off your hosts, right? COVID variants can be more transmissible. Traditional medicine, you identify the risk group, which I believe in. SARS-CoV are variants that potentially cause trouble in the future. Is in virus interest not to be lethal. Public health response, I think I've talked about this a little bit. There's been very poor data about the benefits and very good data about the negatives of this stuff. There's stuff by Ladapo, who's now head of health here in Florida, who's doing great work. Columbus also showed about some of the public health response. And so there's a natural ebb and flow. We've talked about that. When you say cases are rising, remember, is it with corona or from corona? And there's a difference between the different variants. There are people that are clearly publishing now about the negatives of the public health response. Israel has it now, the Great Barrington Declaration, Alex Berenson's book on pandemia, infections come in waves, the masking is equivocal, and it destroys lives. So we have a COVID cycle where everybody gets all bent out of shape and everybody comes in, proclamations and more boosters, the post-shot. Probably in the future, a different formulation I would support. I support this in immunocompromised people. Don't remember we talked about T cells. It really makes no sense for me for adolescents. I'm just going to tell you that right now. For the adolescents and the kids, I just don't get it. I don't get the booster stuff. I just don't get it, right? CD recommends for the general public, if you get a third shot, you have antibody levels. I don't know if I always want to do that because there are some antibodies that you will raise which are negative antibodies. By the way, there's data on this, that antibodies cannot always be a benefit. Remember that there's side effects from the vaccines. And there's about 5 billion doses going worldwide. Operation Warp Speed, I do want to say this, Operation Warp Speed was one of the greatest accomplishments ever. Operation Warp Speed was one of the greatest accomplishments ever. In another scenario with other kinds of things going on, this would have been recognized as a Nobel Prize winning strategy, but for a bunch of reasons it's not. But just like everywhere else, there will always be infections. You're here to stay. The vaccines will get better. We'll get better to understand this. But you should have your primary series for sure. After that, it's up for discussion, and that's it. Thank you. Okay. Do you have any questions, or do I'm good?
Dr. Hyman.
We'll take question at the microphone. Is that what you want to do it? No. Okay. I'm sorry? Oh, I'm sorry. We're on break. I'm so sorry. You guys were great. You lasted for a long time. Fabrice says I have the big hook for lunch, so I'm sorry about that, but I'll be around for questions, okay?
So, Dr. Hyman, thank you for updating us on COVID-19 and agreeing to speak back-to-back for us. On behalf of the IAIM Board of Directors, we'd like to thank Dr. Hyman for serving as president in 2013 and for his ongoing support of IAIM and the Society for Disability Prevention and Management, SDPM Foundation. Dr. Hyman's and Dr. Barr's slide decks are posted on the Whova platform Day 1 morning session. You can access their slides by clicking on Day 1 morning session slides. Now we're ready to take a lunch break. The IAIM Board of Directors and the 2022 Annual Conference Committee would like to acknowledge and thank the following sponsors for their sponsorship of our 35th annual conference: the American Medical Association, ABC Disability, ODG by MCG, Access Administrative Services, and Independent Medical Transcription. During the lunch break, please stop by the sponsor tables, and on the Whova platform, please click on the exhibitor's link to visit our sponsors. Please enjoy your lunch, and we'll see you back at 2 p.m. Eastern Time for our next presentation from Professor Dr. John Stone, who will be presenting on functional neurological disorder. Thank you.